enroll more than 400 clients on 6-month refill. Next slide. So what are the changes we made on the guidelines? So for facility group models, teen clubs have been suspended to limit the exposure among members of the clubs. And teens who are aged less than 17 years are receiving 3-month refill. But teenagers who are aged more than 17 years have been advised to receive 6-month refill. And for community ART groups, so this model have been modified, so it is now limited to community drug distribution. So the recipient of care are no longer meeting in the community for meeting and other support activities. And for facility and community individual models, so all clients are now advised to, all facilities have been advised to dispense 6-month refill. And there is a plan to implement community ART distribution for ARVs, TPT, TB, and NCD drugs. So even in the community, those will be eligible to receive 6-month refill. But for TPT, TB, and NCDs, we are still relying on the stock we have in our central medical store. So most of those clients will be given 2 to 3 month refill. So currently, implementing partners and the ministry, we are mapping out the distribution of clients in the community. And also we are assessing the level of the commodity so that we are able to implement and continue this initiative. And consideration will be given to clients who are currently being sort of locked in other places which is not their usual place where they collect their medicine, so that they collect medicines from the nearest facility. Next slide. So what are the country's resource and priority questions? So we would like to learn from this pandemic that we want to learn the effect of COVID-19 on recipients of care's adherence to ART. We want to learn the trends of missed appointments, because most of the clients are missing appointments because of the lockdown. So we want to learn how this will affect the outcome of from the treatment. And we want to learn the effect of the global lockdown and the COVID-19 on the country's supply chain. And then we'll want to learn about the COVID-19 management outcome for patients who are currently on ART versus clients who are not on ART. And as country resources, we'll be happy to share with other countries our COVID-19 management guideline and protocols, and also the concept note for community commodity distribution.
Hervé, are you still there?
Okay, it looks like we lost Javier. I thought I lost network.
Nope, I didn't. But let's see.
Yes, the final slide.
Oh wait. He's back. He's back. Carry on.
Yes, I'm still here with Dr. Ndala. Can I see the next slide? I think that was my last slide. Okay, this one is only showing our case definitions. Initially, it was based on the traveling history, but now we have changed because we have some few cases which are considered as community transmission. That is why we changed our case definition to the current one, which we consider everyone who is a contact to a suspected case to be considered as suspected case of COVID-19. Thank you. Over to you, Peter.
Thank you very much, Dr. Kambale. We will now hear from Dr. Jeremy Ndala, who will share with us practical application of these policies at the Kambale Government Hospital. Dr. Ndala.
All right. Thank you very much, Peter. And thank you for the introduction. I'm going to share the experience of COVID, how it has affected our daily processes at our RT unit. Next slide. I'm talking on behalf of my facility, which is Mbabane Government Hospital. Mbabane Government Hospital is located in the Mbabane West in Kundla, and the facility serves as a population of approximately 23,489. The facility also serves as a national referral facility to all clinics, health centers, and regional referral hospitals, and they offer both out and inpatient services with a bed capacity of about 500 beds. So the ART unit is within the Mbabane government premises, and it offers activities ranging from testing, prevention, to treatment and care. And as a unit, we have about 10,500 clients currently on ART, with a daily coverage of about 300 patients who are accessing our facility on a daily basis. This unit also serves as a mother facility to 15 clinics in the Mbabane cluster. So when it comes to differentiated services delivery model, we offer fast track, teen clubs, community ART groups, morning refills, and a club for clients with comorbidities. So we are still finalizing the SOP. Can I move to the next slide? All right. So now I'm going to talk about the major changes that we've implemented as a facility because of the COVID-19. So these, we should note that these changes have been put in place to protect both patient and healthcare workers. So the process starts from the gate. So patients are being tried at the gate by our expert client, where they can also wash their hands with running water and use hand sanitizer. All clients are being screened for both COVID-19 and TB symptoms by a registered nurse, but who's working not alone, but working with COF officers before they join the line to access the ART services. The facility has adopted a screening tool for COVID-19 from the national screening tool, as Dr. Kambale has mentioned it. Our clients are encouraged to respect the social distancing, so keeping the 1 meter apart as they join the line. And only 50 patients are allowed to enter in our waiting area. And once they are in the waiting area, they sit, keeping also the 1 meter apart, which means they skip one chair as they sit at the waiting by the waiting area. And the only client in terms of wearing of mask, we only provide masks to patients who have tested positive who have screened positive to either COVID-19 or to our TB screening. But for all healthcare workers, we are providing them the mask. As you can see, the picture, I don't know if it's clear, so you can see the screening tool that was adapted by facility from the national screening tool. Can I move to the next slide? Okay. Some of the changes that were implemented in terms of our DSD models. So let's start with the strategies that we put in place to strengthen our fast track and early morning refills to make it very quick. So we've increased the capacity of our expert client and data clerk so that they can help us with the retrieval of our files and pill count in the morning. And we've encouraged all the clinicians to assist with drug refills and documentation. Before the COVID-19, this activity was only done by the registered nurses. But ever since the country was affected by the COVID-19, so we had to adjust, and request all the clinicians, included the doctors, to assist with the refills and documentation in both the chronic care file and our electronic system, which is CMIS. The facility is also implementing extended working hours. As for now, the facilities opens as early as possible at 5 a.m. and we extend our working hours up to 5 p.m. to allow patients to come and pick their drug. So in terms of DSD group model that were affected, it's only the teen club. For now, we have suspended their activities. So what we did as a facility, we divided our children and adolescents who are on teen club into 3 subgroups, and we called them. They were called by the expert client, and they came on different days to come and pick their drug, and they were given 3 months refill. Concerning the community ART group, the activities were suspended, and now they are only limited to drug distribution. So we've suspended their meeting and other activities in the community. Next slide, please. So in terms of scaling up of multiple month scripting, we followed the recommendation that came from the Ministry of Health to increase our capacity and the scaling up of multiple month scripting. So as for now, all eligible clients, meaning stable clients who are on first line, TLE or TLD, are being prescribed and dispensed up to 6 months supplies. As of now, as a facility, we stand at 976 clients who are currently on 6 month refill. And our target as a facility was 1,030. This one, because of it depend on it to be increased once we are being notified about additional stock of TLD in the country. So we rely on the stock at the central medical store. All stable clients on second line DTG-based regimen are being also dispensed 3 month refill, including those on atazanavir and lopinavir-based regimen. So for clients with comorbidities, like patients with hypertension, diabetes, and those with who are on chronic dialysis, we give them also up to 3 months refills. Clients who are eligible for TPT on cotrimoxazole prophylaxis also are being refilled 3 months supply, as well as patients with advanced HIV disease who are on fluconazole, for maintenance dose. They also benefit from this 3 month refill. So in terms of changes in the supply system, there's no much changes, but we'll scale up the multiple month refill has been slowed for now because of the concern of stock out. So once we are notified about enough stock by the central medical store, we will keep on scaling up our multiple month refill. So I think this marks the end of my slide. The next slide, if you can move to the next slide. This is just a picture that shows how we've implemented the screening. So as you can see, as the client arrive, it's not only for our client, even for the healthcare workers, as you can see on that picture. So they are personnel that are being screened, they are as well as our patient. Thank you very much.
Thank you very much, Dr. Ndala. We are going to do Q&A at the end of all the presentations. Meanwhile, if you have any questions, please put them in the chat box, and we will get to those questions at the end. Also, those of you who just joined us, welcome to the 5th episode of the CQUIN DSD and COVID-19 webinar co-hosted by ICAP, IAS, and ITPC. Please go ahead and type your name, email, and organization or institution in the chat box. And if you are not yet on the CQUIN-COVID WhatsApp group, please add your name, your phone number, so that we will add you to the WhatsApp group. May I now invite Ms. Nopilo Guerrero to respond on behalf of the recipients of care.
Hi everyone, morning. Thanks so much, Peter. And as you have introduced me, I'm Nopilo Guerrero on behalf of the recipients of care. From the previous present.
Please, those who are with Nopilo, if you mute your microphone so that we'll minimize the echo. Nopilo, please go ahead.
I think she may have been muted.
Oh, okay.
Okay. Should I continue?
Yes, perfect.
Yes.
Oh,
yes.
great. Thank you. Thank you. Yes. What we've been experiencing as a recipient of care, first of all, with the situation, we are having challenges with transport in reaching the facilities, especially for those that are supposed to come on the indicated date, which was before the COVID situation. So it has been really tough based on what the country has put in place pertaining the partial lockdown, which also affect the transport in getting to the facilities. So beyond that, currently, the transport are all sort of like, I would say, we have limited transport, which only runs in the morning. So if you miss the first one or maybe the earliest one, it becomes difficult. On top of that, you also need sort of a letter from the community level that says you are going to the facilities, which then now compromise who to disclose to about your status, people that you are comfortable with. So they find themselves disclosing their status at the community level so that they are able to inquire that letter, which will allow them to pass through the traffic cops who will then permit them to go to the facility. And those who happens to leave early to the facilities for their refills, their experiences comes to a point whereby when they are from the facilities, seen loitering around town, waiting for the afternoon transport. So police officers, they will then always require a document which confirms you are from the facility. And some of the ROCs, they don't have sort of like a document from the community or the facility, except for the booklet that they use for refill. So you find that it is then being opened in the presence of the other passengers who are also being inquired by the police officers why they are in town, and confidentiality is not maintained. So they sort of like an unintended disclosure at that moment, and the individual can't have a way of like really confirming I'm from the facility. Yes, it was my date, and my booklet also confirms that I'm from the facility. So then the rights thing, they feel like they are being violated in a way, because it's not sort of something that they are able to consent about, in as much as they would indicate, okay, I'm carrying my tablets, but they will always insist that they want a document which confirms we are from the facility. And above that, there's also the partners are supporting in making sure that everyone comes to the facility, which is the follow-up. In this situation of the COVID, we have noticed that even in as much as some of the ROCs have not fully disclosed to their families, but now this point has made the families to all come together. So if one received a call that says, can we come over or come to the facility to get your medication, then everyone will always ask, why are you going out are you not exposing yourself, until they have to sort of like say it out why they are going to the facility or why the facility is calling that individual. And with the young people, when the COVID situation started, they had to move from where they used to stay, and apparently those parents, they sort of like know the status of the child. So when they are within the community level, they have to go to the nearest facility. And the problem now is that the facility, they've not been there before. They don't know who to contact. They know about clients there, but they've never met them. So it becomes a bit tricky for them. They feel shy, or they always wonder, how will I be accepted in that facility? So some of them, we find that they end up running out of their treatment based on that. Also the issue of, in as much as we're talking about recipients of care, but we also note that amongst the ROCs, we do have a key population, which now brings up the element of like disclosing to their parents of their gender sexuality. Yet when they were going to the teen clubs, no one was really inquiring or wanting more on that, but now they are sort of like compelled to disclose, why am I not doing all these things, and sort of like the home cause, whereby this is how I identify myself. And end of the day, it also affects the treatment side, since they know that if we are not taking your treatment and you are not comfortable where you are, so there will be poor adherence on that. So that's what they've also indicated. I don't know, I think it's all that is the issue of the transport, and in as much as the partners, like in one of the regions, they are really trying to reach the clients at their homestead, but still there are issues of stigma, and some they felt like, in as much as we are bringing the service close, but I'm not comfortable to be seen taking the medication within my home area, I would still prefer to go to the facility. Yet there is that disclosure component when they have to disclose either of the facilities. I think it's that. Hello?
Yes, Nabila.
Yes.
We can hear you. Okay, is that the end? Are you done?
Yes, I'm done. Unless maybe just two submissions, our suggestion as recipient of care, as Dr. Kambale has highlighted in his presentation, based on the 6 months we also feel if it was well implemented, maybe when this time comes, a lot of the clients would already be enrolled in that model, which will half up the number, as Dr. Ndala has indicated that their target was up to 100 and something, but they have lesser than that. And also to modify maybe the outreach part, inclusion of the community adherence groups, whereby in this situation, if we have the community-based treatment groups, sort of like having someone who brings the ARVs to that group, if maybe as a country we consider it to see, so that when such situation shows up, we are able to have all these models tailoring in with any situation that we may encounter as a country. Thank you.
Thank you very much, Nabila Kwebu, on behalf of recipients of care from Eswatini. We'll now move on to Liberia, and we'll hear first from Dr. Michael Odo, who's the TB HIV advisor. Dr. Odo, please.
Thank you very much, Peter, and let me say a quick thank you to the CQUIN team for organizing this opportunity and platform for country experiences. And thanks to Miriam for the WhatsApp platform that was before this and all the huge resources. Thanks to all the NACP and health workers who are the heroes of the pandemic. I want to take us through very quickly a couple of our situation in Liberia, and my colleagues from the facility and PLHIV network will also speak in this session. Next slide quickly, please. Next slide, Laura. So this is a quick snapshot of the COVID situation in Liberia as at 17th of April 2020, with 85 confirmed cases, 7 deaths. But noteworthy is the fact that there were 223 contacts among these cases and 18 confirmed cases among health workers. So looking at the ratio of 18 to 85, that is pretty significant. And that has thrown us, HIV management team, to the triple conflict. And the triple conflict is preventing people living with HIV from COVID, managing the fears of people living with HIV against health workers, as well as managing the fears of healthcare workers towards PL-HIV. Next slide. So 70% of people living with HIV in Liberia actually concentrate in Monserrado. Liberia, the data is there on the screen, has about 40,000 people living with HIV. 26,000 know their status, and about 15,000 are on ART. So 70% of these 15,000 reside in the area shown on the map. And if you can move to the next slide, it magnifies further the focus in Central Monrovia. So this underscores the quick response from the AIDS control program, targeting the facilities that are in Central Monrovia, with more specifically the 13 facilities that carry 70% of the burden. And this is just a response situation in a pandemic, with not much health workers around the country. They need to focus our energy in where the burden of disease is and where the burden of care is required, became very, very necessary. Next slide. From a national point of view, the country had instituted a national and county level case and contact management task forces that have done very tremendously, working closely with the National Reference Lab and Treatment Center, and they report directly to the COVID National Committee under the headship of Mr. President himself. And the interesting thing about Liberia generally is the huge lesson drawn from the days of Ebola. So the ordinary man in the streets, the PL-HIV coming to the clinic, has a high sensitivity and experience with infection control responses because of the previous Ebola challenge. So general promotion of infection control issues like hand washing and cough, sneezing etiquettes got implemented literally everywhere, in the villages, in the town, the cities. The government also introduced strategic lockdown under an emergency scenario to restrict intra and inter-county movements. And of course, engaging the telecommunication authorities and all the mobile operators to hit both the mass media, the telecommunication airwaves, giving real-time updates to the entire population. Next slide. The NACP itself, as the policy institution with the mandate, responded very, very quickly, working closely with the National AIDS Commission, provided, in addition to initial guidance to facilities, a circular and interim guidance went out on the 25th. That interim guidance was circulated to all clinics, and the key content, number one, was to strengthen and ensure infection prevention etiquettes, as listed there. And then, of course, very importantly, putting into place physical infection control strategies, administrative infection control strategies, like reorganizing the clinic flow, making them unidirectional. So recipients of care that are coming in from one edge of the clinic should go out from the other end. And that minimizes contact and enhance the physical distancing recommendation. In addition, as my colleague, Dr. Vera from the Infectious Disease Center will present later on, tents are provided in most of the high burden facilities to reduce the burden of PLHIVs in any one area. The NSCP also advanced a lot of multi-month dispensing to 3 and 6 months. As you'll see in the next slide, 3-monthly dispensing was a standard of practice in Liberia. There was a gradual strategy for introducing 6 months to the high burden facilities, but the NSCP deemed it fit to jumpstart the process, and that jumpstart is moving quickly to the 13 high burden facilities. But ab initio, the oral guidance was for many facilities to, on their own, look at situations and advance recipients of care to 6 months. But to still make it in a very, very coordinated fashion, they need to have all the health workers quickly trained from the 13 high burden facilities on 6-monthly scripting and dispensing had to be instituted to put an order despite the emergency situation. Next slide. So a couple of facilities also, fast track refill was not the practice, but a couple of facilities were high burden, like Redemption Facility Hospital, JFK. These facilities had to introduce fast track refill to minimize the time of recipients of care being available in the facility. It was about the same time of jumpstarting a viral load campaign in the early first, second week of March. So that process got a bit affected. So we are actually in a twist between using one of our criteria for 6 MMD, which is recipients of care should have viral suppression, and the campaign was intended to facilitate that process. So looking at the last 2 bullets there, the 6-monthly scripting is going to become a standard, and as I said, that has to be managed closely with advancing the viral load campaign despite the situation. So strategic approaches of still having the viral load done despite the emergency is quite critical for us. I think we can move to my last slide. So the priority question for COVID and HIV, would like to see how the impact of COVID on missed appointment, loss to follow-up and retention in ART clinics will turn out like. There are a couple of issues related to missed appointment due to the curfew, transportation, fear of infection, which one of my colleagues will also talk a little afterwards. Now, it would be nice to also understand the perception and psychosocial impact of COVID on people living with HIV, on ART, and how it affects care and treatment, and looking in more detail on the impact of the stay at home on mental health, nutrition. And then lastly, there's little study on the co-infection situation of COVID and HIV. Currently, only one PLHIV on ART is co-infected with COVID, and incidentally, we burrowed into it is a defaulter who have been, in addition to being treated, managed for COVID, had to be also placed on intensive adherence counseling and supported for with ART. So lastly, screening for HIV as well as other illnesses is now being included in their COVID-19 management protocol. So thank you very much for your attention, and it's good hearing from other colleagues.
Thank you very much, Dr. Odo, for that quick presentation. Please, to all of us, if you have questions, you may put them in the chat box. The speakers are answering the questions in real time. So if you have questions for the previous speakers, please go ahead and put them in the chat box. Our next speaker is Dr. Neyake Vaye. He's an infectious disease specialist from the JFK Memorial Hospital, Monrovia. He's going to share with us the experience from the front line, how they are implementing those policies as described by Dr. Valle. Please take it.
Hi, everybody. Thank you so much. My name is Nayaka Vey, and I'm a third-year resident at in the internal medicine department at John F. Kennedy Medical Hospital. Next slide, please. So JFK was founded in 1971, and it is Liberia's #1 national referral and teaching hospital located in Cinco, Monrovia. But to be specific, it's located in Montserrado County, and Montserrado County happens to be the largest populated county among the counties in Liberia. Now, patients from all parts of Liberia are brought to our facility for care, but to be specific, most of our patients are from in and around central Monrovia. So the total number of patients on ART in our facility are 2,111. Before the pandemic, we saw 100 patients per day. Now we see only 45 to 50 patients per day. Reason being that we have initiated the multi-month dispensing, and then because of the lockdown, other patients are outside of Monrovia who are comfortable taking their medications at our facility have not been able to come. However, we talk to the facility in their region to dispense the medications. Next slide, please. So to prepare for the COVID-19 pandemic, the hospital gave us extra tents and benches to ensure physical distancing. So the triage, we do triage, and then we see 5 patients at a time. And there's training for COVID-19 using the basic Q&A card that you will see later. All our healthcare workers are fully equipped with the necessary PPE, though we don't have a lot. And we would have loved to provide each and every one of our patients coming for their appointment with their protective gear, but we don't, as at now, we don't have enough for ourselves. So we can't do that, but given the resources, we will be able to implement that. Next slide, please. So this is a sample of the cards, the triage form. You see that there's the name, age, address, and then there's a basic question. We do the triaging there, and basic questions are asked for the COVID-19, to cover for COVID-19. And this is one of our hardworking nurses who is dressed in the kind of PPE that we have, and we also have the moon suit, something we call moon suit, the overall as well. Thank you. Next slide, please. So as it pertains to fast tracking, we have been doing fast tracking. Patients who have been adhering to their medications, they have suppressed viral loads and are clinically stable. They don't need to go through the routine process of seeing a doctor on every visit or queuing up in the facility. So what we do is, once you present your card and we know that you are just here for your medication, we dispense your medications as quickly as possible, and then you are fast-tracked out of the clinic. Next slide, please. We have been doing, to reduce the number of inpatient and outpatient visits to the facility during this pandemic, we have been doing the multi-month dispensing, and we took into consideration patients who have been in care for 3 to 5 to 6 months and are adherent on their medications again, stable, and are virally suppressed. For those who we recently initiated on ARTs, the meds are dispensed on a monthly basis because we want to do a regular checkup and ensure that they are adherent to their medications. We have also been doing this for patients who come in with non-communicable diseases, as well as the TB patients. The TB patients are being given a 2-month late dispensing. Next slide, please. So we have suspended we have stopped all group models, no meetings, no group counseling. Patients are seen one at a time. And to decongest our clinic, we have, and also to limit the exposure of healthcare workers, because that's what we faced during the Ebola virus time. We have decided to, along with administration, to reduce the number of staff per clinic visit, and most of these staff are in 3 days per week on an interchangeable basis. So our National HIV and AIDS Control Program are so generous to us, and they have supplied us with enough drugs that will be able to cover for this, or to absorb the COVID-19 response strategy. So thank you.
Thank you very much, Dr. Vin. Our last presenter is Mr. Fulfil Musa. I hope I'm pronouncing that correctly. He's the program manager for representing ITPC in Liberia. He's going to respond on behalf of recipients of care in Liberia. Mr. Musa, please take over.
Thank you very much.
You have 3 minutes.
Thank you very much for this opportunity, and I hope that everybody is hearing me well. From Liberia, we first talk about what is working well during this COVID-19 crisis. We have ERV available. We have the ERT centers open for recipient care. We have the multi-month scraping for stable recipient of care in place. How are recipients of care seeing the COVID-19 and the ERT centers? So fear of contracting the COVID-19 is high among the recipient of care and the general population. We have, healthcare workers are stigmatized against diseases like COVID-19 and Ebola. What are the challenges recipients of care experiencing during this COVID-19? Higher transportation costs due to the lockdown. We have a limited vehicle giving the street. So we have that, because of that, the transportation is high. And then we have a long queue to get into the ERT centers. Inside the ERT center, you have the distance provided by other organizations, the build shuttle. But before getting in, you see a long queue there. Before getting to the hospital, which making social distance impossible. What need to be improved? Community engagement to reach out our peer. Monitoring of care services by the network of persons living with HIV. During this time, because of the limitation, we are unable to see exactly what is working at other facilities. Because of the time, I think I just wrote a few things, and thank you very much.
Great. Thank you, Mr. Musa. Thank you to all the presenters for very good presentations. I think we have time for a few questions. I've seen that a lot of the questions have already been answered in the chat. So thank you to the speakers and to those who posted the questions. There are some 2 questions that I'm going to just read it out and ask the presenters to respond to them. So the first one is to find out how countries or health facilities are working to protect essential services like immunization during this period. Maybe, I don't know if Javier you want to start, and if Michael you have something to add.
Okay, thank you for your question. May I please ask Dr. Kindandi, who is on the call and is part of the SRH team in Eswatini, if he can.
Sure.
Dr. Kindandi, please. Or Dr. Lydia.
Okay, so good afternoon, everyone. I think Dr. Kindandi must have just had trouble with his internet. So the SRH in Swaziland is working very closely with IPs in order to see how we can mitigate some of these challenges that we're beginning to see in some of the regions, and trying to see how we can align a lot of the services with the ART bill. So they have developed slides for the COVID response that speak specifically to MNCH and MNCH services. And this, we are currently have just begun sensitizing facilities, and we hope that with this sensitization, which is paying attention to SRH services in general, that we will see not such a bad decline in the uptake of services.
Okay, thank you very much, Dr. Lydia. Mike, are you adding something?
Yeah, so I think facilities at various levels of sustaining the integration, based again on HR capacity, and it would be nice for Dr. Vera to speak a little how it's happening in JFK. But in the 13 facilities, they have the luxury of the support of the Linkages project. The Linkages project is supporting care and treatment with IT supported by FHI 360 with USAID funds. So they have the opportunity of a few food soldiers, they call them the Linkages referral coordinators, and the focal persons. So through these point persons, capacity building has happened earlier, and they are strengthened to support other services that are beneficial to PLHIVs of all age groups, SRH being one of them. Dr. Benaya, we're going to put some.
Sorry, Marka, I didn't actually get what you wanted me to say as it pertains to what? Sorry.
Yeah, I thought for SRH, will you want to put words how it's being sustained in JFK right now? Sexual and reproductive health integration with HIV in JFK.
So as you are aware, we have the IDC clinic that is on the other side of what everybody is following. We are by the help of linkages, which of course I'm one of the linkages retention coordinator. We are all working with the focal person to continue the SRH in our facility. Now, recently we had some problems in the maternity wing of the hospital, and we had to close down for a bit, but we can guarantee you that services are continuing as planned. I don't know whether I touched what I was supposed to touch. I'm not sure.
Thank you very much, Dr. Abey. I saw that question for Eswatini. Can Eswatini provide a brief description of how community distribution of ART is being done? How many clients are called to each marked out spot? Are you using some form of time appointment system, or do the ROC come in groups?
Okay, thank you for the question. So this one, I think we plan it together with all the implementing partners, PEPFAR, MSF, and WHO. So the idea is we recommend partners to go to the facilities and check the appointment register. For example, clients who are coming in May, there will be calls individually to ask them where they are currently residing. And then this will be like a quick activities to just map out where clients are. And then I think the facility, together with partners, we plan sites visit for community distribution. So this is, so the priority will be given for clients who are coming in May. Then they will call clients who will be coming in June and in July. So the idea is to have maybe a certain number of clients grouped in a certain area in the community so that the facility is able to go and do the drug distribution in the community. That is how we are planning to do that. And also we say that we are expecting other clients to come as visitors because they might be currently residing far from their facilities. That is why we will be using a standard form which is having different elements of the electronic system so that when the client refills in that area, information will be put in that form and then update the electronic system, which is currently interlinked. Maybe one of my team from Eswatini can add, if possible. Thank you.
Thank you very much. So I see that there are some hands that have been raised, but unfortunately we are out of time. So please feel free and write your questions in the chat box and we will follow up with you. The speakers will respond to them. I would like to use the 0 time left to just announce that our next week webinar will be on DSD, COVID-19 and reproductive health services. We'll be sending you the links for you to sign up for next week. Thank you very much to all the presenters and thank you all for joining us. Have a good day.
Okay.